Confusion is one of those chief complaints that, well, feels confusing. So if confusion questions make you feel confusing, you're not alone. Most students struggle with this chief complaint, not because they don't know enough neurology, but because they don't anchor their thinking early. They hear confusion and immediately think everything from stroke, dementia, infection, what labs to order. But that's not how clinicians think. Instead, they use a simple, organized framework. First, rule out anything dangerous, then use time course, and finally, look for key diagnostic patterns. If you can do this, confusion goes from feeling overwhelming to something you can narrow down quickly. In today's video, we'll walk through a case of confusion, and I'll show you how this framework makes your process so much easier. And later in the video, I'll show you the key diagnostic fork that dramatically reduces your differential list. Let's dive in. Let's apply our 5-step framework to a patient. Let's say we have a 78-year-old female who presents with confusion. Before even walking into the room, we should already be thinking, what's my broad differential list? What focused history questions will matter? What targeted physical exams should we perform? Then we'll update our differential list to a more narrow working diagnosis and our top differentials, and then present our findings in a case assessment. So first, we build a broad differential list. Confusion can have a rather large list of differentials, but most causes fall into a few major categories. Infection, which is very common in older adults. Metabolic causes like sodium or glucose abnormalities. Neurologic causes like stroke or hemorrhage. Medications or toxins. Polypharmacy is especially important to screen for in an older adult. And cardiopulmonary causes like hypoxia. So at this stage, we're not trying to be right. We're just trying to be complete. Next, we'll use focus history questions to help us narrow down this list. So step 2 in our framework is asking focus history questions. And this is exciting because this is where our diagnosis list starts to narrow. So instead of ordering labs, we want to start with targeted history questions. First, we want to understand the onset and time course of their confusion. So we could ask, what were they like 1 week ago? This gives us a good baseline. If their confusion has been going for hours to days, that's probably more likely delirium. But if it's been going on longer, like months to years, that's leaning towards dementia. Next, we want to clarify what kind of confusion they're experiencing. Is it wax and wane? That's more likely delirium. If they're experiencing impaired attention, that's also a hallmark of delirium. Any recent illness, symptoms of fever, cough, dysuria, that's leaning more towards infection. We want to be sure we ask about medications, whether they're new, if they're taking any anticholinergics, sedatives, and a good reminder to always review the beer list for medications that can affect older adults. We want to check for falls and trauma. This could be indicative of a subdural hematoma causing their confusion. And then it's good to ask about any substances like alcohol or benzodiazepines. And then we always want to ask about red flags. So the pattern of fever and confusion could be associated with infection or sepsis. Severe headache could be more indicative of an intracranial bleed, meningitis, any focal neurologic deficits or signs of stroke. Sudden onset within hours or minutes could be a vascular event. If they've had decreased loss of consciousness, that could be an airway risk. Recent falls or head trauma, we discussed as a subdural hematoma. Any seizure activity, they could be in a post-ictal state or have some sort of CNS pathology. Hypoglycemia symptoms would be indicative of a metabolic emergency. Any shortness of breath could be respiratory failure or pulmonary embolism. And stiff neck or photophobia could be meningitis. So here's an algorithm I created to help tease out what's going on with confusion in an older adult. Hopefully this will help us put everything together and make it not feel so overwhelming. So first, we always want to rule out or ask about any red flags. If there are any red flags, we definitely want to refer for urgent ED evaluation. If there aren't any red flags, as in our patient today, then we'll use time course to narrow down our differentials. Remember in the beginning of the video when I said there's a key diagnostic fork? Well, this is it, time. So if the patient's experiencing chronic symptoms like months to years, that leans more towards dementia. But if they're experiencing confusion over hours or days, it's more acute, and that's more indicative of delirium. So if there is signs of delirium, we would use patterns to help us narrow it further. Do they have any inattention or fluctuating course of symptoms? That could be indicative of infection, medications, metabolic causes, or even a CNS event. Your key clinical pearl here is that delirium is acute plus fluctuating plus inattention. So you always need to find the underlying cause of delirium. We can't just leave it at delirium. So we've gathered enough information from our focus history questions and red flags to present our case. We have a 72-year-old female brought in by her daughter who presents with acute confusion that began 2 days ago. Her daughter reports fluctuating alertness and difficulty maintaining attention. The patient is disoriented and unable to follow simple commands. She reports urinary discomfort but denies cough, chest pain, or recent trauma. There are no recent medication changes or substance use. Okay, step 3 is performing targeted exams based on what we learned from our focus history questions. Our first differential here is delirium, and we want to assess attention and cognition. So a MOCA exam would be a great way to do that. We could also gather general information, and then I'd want to perform a neuro exam. So let's assume for our patient today, there's signs of inattention, disorientation, fluctuating alertness, but no focal deficits. If we suspected an infection, like a UTI, it'd be good to perform a neuro exam, but also an abdominal exam and look for suprapubic tenderness to palpation and perform vitals. So for our patient, let's assume there's mild suprapubic tenderness and a low-grade fever. Next on our list is pneumonia. So we'd probably want to do a heart and lung exam. Be sure to gather pulse oxygenation, and then I'd still want to perform a neuro exam. Lungs are clear for our patient today, no crackles, and O2 sat was normal. For stroke, we definitely want to perform a neuro exam, making sure we go through the cranial nerves, test strength and speech. For our patient, let's assume there were no focal neurodeficits. And lastly, dehydration. We'd want to perform vitals. We'd also want to check mucous membranes and skin turgor. And then I'd probably still in an OSCE situation perform neuro exam. So for our patient, let's assume dry mucous membranes, possible mild tachycardia. So now on step 4 of our framework, we're able to refine our differentials. So we're not adding any diagnosis probably at this point, but we are prioritizing. So based on what we've identified, I think there's a pattern of delirium, and we need to figure out then what's causing it. So I'm thinking a UTI is pretty likely here, but I still want to keep medications on my list. So remember, if patient presents with confusion, you want to think about the causes. And for delirium, it's important that you use pattern recognition to help you find that cause. So step 5 in our framework, we can pull everything we learned together and present our assessment. So we have a 78-year-old female who presents with acute confusion over 2 days associated with fluctuating attention and disorientation. In-office exams today are notable for impaired attention and mild suprapubic tenderness. The acute time course, fluctuating mental status, and inattention are most consistent with delirium. A likely trigger is urinary tract infection, given urinary symptoms and exam findings. Alternative causes such as dehydration or medication effects are still also possible, while stroke is less likely given the absence of focal neurodeficits. Given this presentation, further evaluation is warranted with labs and a UA is indicated. Before we wrap up today, I want to share 3 common mistakes that students make and ways you can avoid that. The first trap is calling it dementia too early. Be sure you start with the time course and ask about how long the confusion has been going on. Because remember, if it's acute, then it's more likely delirium. Number 2 is skipping attention testing. So always test attention. And remember, delirium equals inattention plus fluctuation. And number 3 is missing red flags. Be sure you assess for stroke, infection, hypoglycemia, because these can be life-threatening. And a good pattern to remember is if there's fever, focal deficits, and decreased consciousness, then that's an urgent eval. If you take one thing away from today's video, I hope that it's the key to a case of confusion isn't about memorizing a long differential list. It's about asking the right questions. So be sure to rule out any red flags like stroke, sepsis, hypoglycemia, hypoxia, and then use the time course to guide you. So in today's case, we had acute plus fluctuating plus inattention. That's pretty classic for delirium. Use those key diagnostic forks to help you narrow down your differentials. If you want to get faster at clinical reasoning, not just for confusion, but for any chief complaint, I break down how to apply the ScrubNotes framework across the entire Chief Complaint Series, linked here. So if this clicked for you, check out the rest of the videos. Thanks so much.